my passion and working with our patient and Indigenous partners over the last probably 10 years of my life now, which culminated in the a paper that Sarah wrote. We've have quite a wide publication stack of things we've done over the years with our work with First Nations and chronic kidney disease screening, triage, and treating patients. And we'll get into some of the details there. Also like to acknowledge a lot of this work, not all of it, but a lot of this work is also being funded and strongly supported by our CanSolveckd network, which is a sort of national network of patient-oriented research projects, of which one of them is early detection, treatment, and surveillance of chronic kidney disease. And so just acknowledging a lot of the strong work done there, but otherwise this work that presenting today has been funded in part by grants from the Health Services Innovation Fund, from the federal government, from CanSolveckd and a number of partners, including Kidney Foundation of Canada, Research Manitoba, the Manitoba Renal Program, a lot of other groups there. And now actually live in British Columbia, soon to be when the pandemic is less acute in Alberta, Saskatchewan, and Northern Ontario, in addition to Manitoba. So format wanted to present today. Thanks for the introductions, Sumedh. I'm going to hand over to our lead patient partner on this project, Cathy, to introduce herself and the strong role that patients, specifically Indigenous patients, we rely on their time and expertise to help guide our project as well as our key deliverables. Sarah, who's one of our lead research coordinators now, we're going to tell you a little bit about the nuts and bolts of the program, and then I'll sort of get into, in the last half, some of the future directions, and then hopefully we'll have some very productive discussion today. So with that, thank you, and I'll hand things over to Cathy.
Hello, can everybody hear me?
Yes, Cathy.
Yeah. Welcome, everyone. My traditional name is Miigwech Miigwech, which means circling golden eagle woman. The name given to me by my elder, and his words to me were, "You are always there, you are always around, you are ready as a grandmother, mother, sister, auntie, friend, and colleague to help out, guide, and just be there. Be present and be in the moment." I am Cathy Woods, a Anishinaabe woman originally from Ontario and now residing on Treaty 1 territory in Manitoba. So today I'm going to share with you who I am, why I do what I do, and the benefits of patient engagement. I'm a member of CanSolveckd Patient Governance Circle and a member of the Indigenous Engagement and Research Council. I have held leadership positions in both groups, and I have been involved since 2015. I'm a patient lead on the Kidney Check project. And so next I'm going to just give you an outline of a very brief outline of my story. In 2010, at a routine physical conducted by my primary care physician, the results were not good. Went back to the doctor in October and with a diagnosis of nephrotic syndrome. I had rounds and rounds of tests and scans as they were trying to find out what was going on in my body. I had lots of different meds for high blood pressure and all of the other maladies that go along when your kidneys are not doing what they're supposed to be doing. I had 12 times as much protein in my urine as the normal. That led to a low protein diet and lots of stress. 2 months later, after a kidney biopsy and meeting my renal specialist, Dr. Komenda, a diagnosis of membranous nephropathy. So basically the kidneys in the filters in my kidneys weren't working very well. So fast forward to the summer of 2011, we started an aggressive form of treatment with chemo and lots of other meds. After a period of about 10 months, my disease abated, although I was left with the side effects of the meds for a very long time. I tell you this because of many different reasons. I was a healthy person at the time of my diagnosis. I had no symptoms of disease for about 3 months. And then I started suffering from swelling, fatigue, and just general unwellness. I had a primary care physician who routinely did tests. I had access to a renal specialist who supported me in a timely fashion and also supported my desire to use traditional healing methods in my kidney journey. And for most of our Indigenous folks here in Manitoba, that is not the case. 80% of the damage done to kidneys is done even before you know that you have the disease. We work with community and their leaders on a process that works best for them. We partner here in Manitoba with the Manitoba First Nations Health and Social Secretariat. We work together with them. Being a patient partner in Kidney Check in CanSolve is why I do what I do. It is my chance to give back to the community who supported me in my kidney journey. Being involved in patient engagement leads to better research that affects our lives as kidney patients. It is valid and necessary exercise to improve the lives of all kidney patients. Having a voice at the research table is vital to the process. To be actively engaged in priority setting and setting of health policy, and in what research will benefit us as patients. It is a valuable tool for effective research. We are involved every step of the way. It is valid and a sustainable, it makes a valid and sustainable research project. And with the assistance of my renal team and my community, I was able to realize good health and even better spiritual, emotional, mental, and physical health. I'm afraid at some point that my disease may come back. This is how I survived and how I plan on being part of the solution moving forward in a good way. It has been my pleasure to be involved in kidney research, and working with Dr. Komenda and the team has been one of the highlights that I still continue to do, and I'm forever grateful for the assistance of Seven Oaks and the research team, and specifically Dr. Komenda and his team for everything that they've done. And I will continue to do the work that is necessary to make sure that everyone in Manitoba, regardless of race, regardless of social standing, regardless of anything, gets the right care at the right time. Thank you, and Miigwech.
Thank you, Cathy. So I'm going to just go ahead and start with a little bit of background here. Chronic kidney disease is a pervasive condition. It affects approximately 1 in 10 Canadians, which is around 1.3 million to 2.9 million individuals across the country. Chronic kidney disease diagnosis is given if there is kidney damage or reduced kidney function for more than 3 months with an estimated glomerular filtration rate of 60 milliliters per minute or less, or the presence of abnormalities in urine sediment, renal imaging, or biopsy results. It's commonly caused by diabetes or high blood pressure and is associated with increased mortality rates and cardiovascular events. And over the past decade, rates of CKD and subsequently kidney failure have continued to rise, particularly among Indigenous peoples. In Indigenous peoples, CKD is often diagnosed at a younger age and greater severity. Unfortunately, in many northern communities, primary healthcare is not accessible due to geographical, economic, or cultural factors, and this can result in people delaying seeking help for their condition. As a result, these individuals lose the preventive health benefits that are associated with the continuity of care. And often when they reach advanced stages of disease or require dialysis, are required to leave their home communities behind in order to seek that kind of care. The Kidney Check program is a comprehensive screening, triage, and treatment program that is working to bring culturally safe preventive kidney care to these rural and remote Indigenous communities across Manitoba, Ontario, BC, Alberta, and Saskatchewan. The Kidney Check program was launched in 2018. It is one of 18 projects that comprise the CanSolveckd network, which operates under the guidance of the National Strategy for Patient-Oriented Research. CanSolve and their affiliates are guided by research priorities that were set by patients and their caregivers. This was a 3-year consultation process, and these priorities were finalized during 2 workshops held with patients and caregivers, policymakers, educators, and academics, and other stakeholders. Kidney Check addresses several of the priorities, including early identification of kidney disease, appropriate risk stratification, and timely access to therapeutic intervention within an entirely Indigenous context. The CanSolve program and Kidney Check are guided by the Patient Governance Circle and the Indigenous Peoples Engagement and Research Council. The Patient Governance Circle, it consists of patients and caregivers with a broad range of medical conditions, and they meet quarterly to discuss the CanSolve's program. IPARC is patients, caregivers, physicians, educators, social workers, and provincial and federal policymakers who continuously work to ensure that the program is establishing culturally safe collaborations with Indigenous communities that encompass the OCAP principles of ownership, control, access, and possession. So this is just an image of our point of care testing equipment. When community members arrive at the screening event, they're shown a brief video outlining the purpose and process of screening, and are then able to provide their consent and some basic demographic information. We take BP and analyze blood for blood chemistry values, urinary UACR values, and hemoglobin A1C levels. All this information is inputted onto the Kidney Check mobile application, where EGFR is determined and risk of progressing to kidney failure in the next 2 to 5 years is estimated using the kidney failure risk equation. So these are kind of the main priorities of Kidney Check. When CKD is identified early in disease progression, it can be monitored and treated by medication and lifestyle modifications. Following screening, all patients are offered risk-based counseling and education. These discussions emphasize a holistic approach to kidney health, and high-risk patients are immediately referred to a multidisciplinary CKD clinic where they can establish a long-term treatment plan. In many instances, this allows patients to remain in their home communities, monitored remotely until their disease progresses. It also gives them an opportunity to be educated on their condition, and hopefully provides a more optimal dialysis start where patients are able to start with their preferred dialysis modality should they need it. So this is our kind of core team, the project leadership group. The program is run out of the Chronic Disease Innovation Center, and we work closely with the First Nations Health and Social Secretariat of Manitoba, Shared Health Diagnostic Services, and the team oversees the other provincial teams. So as I said, the project leadership team works in tandem with the provincial team and our community and patient partners. The provincial team is the local patient partners, adult and pediatric medical leads, the region's project coordinator, and a Kidney Check trained screening nurse. Kidney Check is a standardized program. It's accountable to a quality assurance program, but since it is national, a degree of flexibility is required. And so the provincial team's primary role is to ensure the program is adapted to reflect the context and cultures of their respective regions. They are also critical in establishing and maintaining partnerships with local health authorities and healthcare providers. Our community partners are community leaders, elders, healthcare providers, and they provide insight on how to best use engagement strategies to get a good turnout at our screening events and coordinate local resources. We start building a relationship with the community as early as possible by meeting with the chief and council and then the community at large to discuss the program and answer any questions that they may have. Our patient partners, they offer some experience, they offer some insight into their experience managing CKD, which guides the program's design, implementation, and communication strategies. And when the program is introduced to the community, the patient partners often attend to share their stories and experiences and advocate for the importance of screening and a holistic approach to disease management. Paul?
I was muted. Sorry, Sarah. Thank you very much for a great overview of. It's always nice to hear somebody else present some of the work that I've been working on in a very eloquent way. Obviously, the pandemic throws a wrench into the works when you're dealing with in-person point of care screening in what are often rural, remote, but also very vulnerable populations in terms of spread of COVID in these communities, and a lot of our Manitoba-based communities have been hit extremely hard with COVID, and it's getting better now, which is fantastic. It's forced us to sort of rethink a few things in terms of how we sustain Kidney Check. Obviously, these are initially grant-funded type programs, and we've published an extensive set of different knowledge translation aspects of the program. So around, what are the nuts and bolts of the program, like the paper we're sort of talking about today in terms of summarizing all the different partnerships we've had to establish to execute this successfully. We've published a lot on the epidemiology of chronic kidney disease in some First Nations communities, suggesting a threefold increase in chronic kidney disease, and we've seen other elements published in other provinces and so on, that Indigenous peoples have about a 2 to 3-fold increase in dialysis. So Manitoba, as an example, is 15% First Nations, comprising 30 to 40% of our dialysis starts, which is obviously really disproportionately hitting these communities hard. We've published in a cost effectiveness analysis on the incremental cost of doing a program like this, which obviously involves new spend, sending teams up north, buying equipment, doing quality assurance and that, and then looking at sort of lifetime horizon reduction in dialysis starts and cost savings down the road, clearly showing spending money on prevention efforts like this that are innovative and catch disease early are far more cost effective than building dialysis units in remote northern communities. Sometimes that's a hard sell, and they're not mutually exclusive decisions, but it's often easier to frame it that these prevention efforts do have a significant amount of benefit. And I think this is part of the reason why we've been successful in deploying this program now across different provinces, because the idea sort of resonates with people. Depending on what province we've gone into, it's been slightly a different flavor. BC's screened, and there are over 10 to 15 communities now. Alberta has selected a couple of communities close to Edmonton to start off with community partnerships there. Saskatchewan's got now, they haven't launched yet, but a fully provincially funded program around Kidney Check. And Ontario Renal Network is also funded provincially with government funding now, these types of programs in some of the northern communities there, using a lot of the sort of Kidney Check standard operating procedures we've developed. So clearly, this has been validated by a lot of provincial governments now, renal programs, that it seems to be a good idea. And that's really encouraging. We've also been recognized externally with a global award called Univance, which is sort of, we were one of the top 3 global prizes for innovation in healthcare delivery this year, which was really quite an honor. So we have this great idea, and we can't really do it in person. Therefore, we're forced to pivot with our patient partners and other partners, and what could we do differently in terms of providing primary chronic kidney disease screening and connecting people with care, because kidney disease didn't go away just because COVID happened. And so some of the work we're working on now is to deploy a virtual version of Kidney Check, where we can actually interrogate administrative sources and lab sources of data within the province of Manitoba. And we're going to be running a randomized control trial and sending lab requisitions to patients directly who are at risk of chronic kidney disease, say they're diabetic or have hypertension and maybe just haven't been completely screened with an EGFR and urinary ACR testing. And we're randomizing patients to actually send them lab requisitions to go get testing versus just giving them information on where to get screened in a traditional lab. And then we're going to be following up those results and connecting people with care virtually, either using a physician assistant and virtual care platforms, but we will be following up on all those results ourselves. And this really lends itself, it's not like we've invented this model of care, it's just new in chronic kidney disease. People are sort of shocked to realize that if you're a new dialysis patient, your mortality is probably worse than that of most metastatic cancers. There's been good publications on this. So it's a high risk feature or disease that we can prevent, notwithstanding in Indigenous communities, if you're forced to, say, relocate from a rural community or remote community to a city, it's a tremendous impact on your life and your quality of life, and your support network's gone. In fact, there were studies done in northern Alberta suggesting that a lot of people forced to relocate from a remote First Nations community to Edmonton would give up sort of 5 to 7 years of, or even 8 years of life, just to not have to relocate, which is quite a sobering statistic. And so, we really need to rethink how we provide chronic kidney disease care. We now have very good treatments for preventing progression, in addition to ACE inhibitors and ARBs and blood pressure control. SGLT2 inhibitors, a new class, originally a diabetes medication, but I'll argue is primary a kidney prevention medication, can reduce the risk of progression by 30 to 50% in some cases to dialysis. So we have very potent preventative pharmacologic interventions, in addition to all the lifestyle things that we try to promote as well. So taking this public health approach using administrative sources of data akin to how cancer care and sort of infectious diseases have been working for decades now, I think is really one of the future features of Kidney Check that I would like to endorse. In addition to promoting in areas where sometimes that access to care is certainly deficient, we will still go in with our point of care testing equipment and do the wonderful stuff that Sarah was summarizing in across Canada. And we're working towards developing sort of a charter or memorandum of understanding with provinces to sort of standardize some of the work that goes into Kidney Check, elements including make sure we have authentic engagement from patients, authentic engagement for First Nations communities, solid training and quality assurance programs to support the equipment we're using, and ensuring every patient screened is followed up with some sort of care plan, that we don't just screen and leave and have patients flailing around not knowing where to go with their results. So whether it be a primary care or specialty care follow-up, that we really close that loop and we report the data back and have the communities own their own data. In terms of respecting OCAP principles for Indigenous research and health. So really transitioning this from a research program to a fundamental thing that we do as Canadians to deliver better care overall for chronic disease patients, specifically in First Nations populations. In terms of scaling this program now, we were actually quite successful. About a year and a half ago, we received an additional $1 million from TD Bank, and this is again like a sort of a social impact bond grant that again was North America wide. We received one of 5 $1 million prizes in Manitoba to scale up the intervention, and we will be applying some of these resources to do more Kidney Check communities when we can, and things opening up in the next hopefully 6 months to a year. But in the meantime, we'll be redeploying some of this TD money to test case our virtual Kidney Check program, where we're actually remotely screening people and then connecting them with care. So that's kind of an exciting development. and really making sure, just wanted to reinforce that this is the goal of this is to become a sustainable national platform, both in-person CKD screening with point of care testing equipment in a very standardized way, obviously recognizing there's going to be nuances and differences in different provinces with how they want to apply maybe referral algorithms and so on, but that we have certain key elements for kidney check that we adhere to that I described earlier, across the different provinces. We've had a lot of also interest internationally in other high-risk communities in sort of American Indian populations and Indigenous populations in Australia, even in as far away as Africa, where there are a lot of chronic kidney disease, no dialysis resources, but could we deploy a low-cost solution for preventative efforts in those types of areas? So it's not, when I say commercialize, it's not about certainly deriving profit from this, but being able to like take the core elements of kidney check and apply it in other jurisdictions. And I think that sort of Univant's Global Award was really something that I think will amplify the voice of this program to other international markets. We'd be happy to facilitate these things there. So with that, I'll sort of leave it and hand it over back to Sumedh and the team for conversation and questions. And thank you so much for inviting us to present today.
Thank you.